But this came out in the New England Journal of Medicine of these 5 individuals that were hospitalized in New York, and the ages range from 33 years old to 49. So these are young individuals, 1 female and 4 male, and these people are, 2 of them had no prior medical conditions, no prior history of stroke. The other 3 did have some history of high blood pressure, high cholesterol, diabetes, which we know are risk factors for developing stroke later in life. Certainly very atypical to have one at 39 or 44. But I'm curious to hear a little bit about what you make of this, because these 5 young people presented to the hospital and they all had strokes, and some of them had seemingly some of their blood work, for instance, or even other symptoms were seemingly either mild or non-existent, yet they presented with strokes with COVID-19 at a young age.
Absolutely. I think the first thing I would mention to people is that we have come into, I've had the privilege again of training 3 guys. I'll mention Dr. Esteban Chang, John Terry, Brian Ludwig, and of course, I'll mention Dr. Jacobs as well. Some of the most fantastic stroke neurologists in my training. And they instilled kind of to me the concept of stroke, and so the first thing is, let's start with this. It's an interruption of blood flow. Mm-hmm. And so just like I think the autoimmune diseases are essentially one underlying disease with multiple clinical appearances. So before we had all these blood tests, a rheumatoid arthritis patient looked nothing like a diabetes type 1 patient, who looked nothing like a thyroid patient. Mm-hmm. But the first 9 steps are about the same. Your immune system gets primed up. It picks something to attack. That's you. If it turns out to be your pancreatic beta islet insulin producing cells, you have diabetes. If it turns out to be your joint, you have rheumatoid arthritis. Mm-hmm. So about the same thing. Now, I will mention a couple terms, and they are largely the same thing. Stroke, we think of as an occlusion of blood flow in the brain. But it's the same exact thing as something called a pulmonary embolism, which is a blood clot in the lung blood vessel that stops blood flow. Remember, this matters because oxygen is in the blood. So if you block blood flow, no oxygen gets to the tissue dies. So pulmonary embolism is a stroke of the lung. And a stroke is a pulmonary embolism, a cerebral embolism of the brain. And a heart attack, usually, there are some exceptions, is an occlusion of a coronary artery. So a heart attack, a stroke, and a pulmonary embolism are pretty much the same thing. Now, they can happen acutely or chronically. So the way we think of stroke, why, first of all, Dr. Weatherly, I think I'd answer this question first is, why do we care? Why is this atypical to people that these young people are having strokes? Well, as we know, the typical people that present with stroke, which at one point or still is the number 1 cause of disability, I believe, in the nation, I could be wrong, is, usually men of senior age, so usually 60 or higher, smoking, high blood pressure, diabetes, high cholesterol defined as an LDL, which is kind of the quote unquote bad cholesterol, over 70, and also something called atrial fibrillation, which is the most chronic irregular heart rhythm, which can churn the blood, form a clot, which can dislodge and go to the brain. So these happen over time. Like I talk about the paint on the house. If you look at a picture of a house when you first buy it and then a picture 20 years, it's amazing how the grout, the paint has faded. And from day to day, you don't really notice it. But if you look at a 20-year picture, you see the wear and tear. And over time, those blood vessels get worn and torn. And you eventually have endothelial or inside of the vessel damage, and you form a clot or an occlusion, and you have a stroke. Same thing with coronary artery disease. If you keep eating like that, you're going to have a heart attack. Right. Meaning if you keep ingesting cholesterol, not exercising, you will build up enough gunk in your pipe, in the heart, your blood vessels, coronary arteries, they will become occluded or blocked, and you will have a heart attack. That's how this normally plays out. We joke around and say to kids, look, the 20-year-olds that smoke, they say, well, nothing's happened to me yet. I said, listen, man, you can smoke 2 packs a day when you're 19 and probably nothing will happen to you. But when you're like late 40s, 50s, 60s, 70s, you're going to pay the bill for that. You know?
Right. It's a cumulative process.
It's a cumulative process. You got it. Nothing happens the day you have your first cigarette, typically. So how then does this happen? Because that's why it matters. Everybody's saying, well, wait a minute.
This is
right. I got a 30-year-old who's like previously a marathon runner with no known history of anything, any medical condition, no diabetes, no smoker, no blood pressure, phenomenal. You know, their BMI is probably like, 20 at that age. At least I felt like I could eat whatever I wanted at 20. These are like the pictures of health, and they're having a stroke. How in the world does that happen? Well, if you look at the outside pre-COVID world, if I saw a stroke in the young, as we called it, come in, what would I think of? I would think of two main things, other than obviously illicit drug use, like cocaine could do something like that. But let's say we discard that illicit behavior. Blood clotting disorders, which usually are hereditary, but are genetic mutations of the way the blood clots form. You overform blood clots. Women sometimes can present with recurrent miscarriages. That's the case in something called antiphospholipid antibody syndrome. Factor V Leiden mutation is the most common coagulopathy, we call them, or pro-blood clot disorder. Prothrombin gene mutations, right? So if you were a young person, 35-year-old comes in with a stroke, I would check what we call a hypercoagulable workup. Yes, exactly. So blood clotting disorder. The other thing I would think of is something called vasculitis. So lupus patients, if a lupus patient comes in with it, especially if you know they have lupus, if they've yet to been diagnosed, it's a little more tricky. But let's say a young female, kind of in the autoimmune alley, the 20 to 40-year-old female with lupus. Let's say they say, hey, Dr. Pitts, I have a history of lupus. I have this really bad headache, and it doesn't fit the criteria of migraine. It's not hemicranial, throbbing, moderate to severe intensity, 4 to 72 hours with light and sound sensitivity and nausea and vomiting. It is a complete headache throughout my whole head. It is very intense. It's not light or sound sensitive, but it's just like out of nowhere. I've never had this problem. It's not related to my menstrual cycle, as migraines can sometimes be. It's just out of nowhere. I would be thinking of vasculitis, which is the same inflammation in an autoimmune disease that would attack the joints. Let's say in lupus, could attack the blood vessels of the brain. And vasculitis is something you always have to think about. And there are actually genetic disorders that predispose people to that. So all of a sudden the thinking would shift in a younger person if they had a stroke pre-COVID. I wouldn't be thinking about blood pressure, diabetes as much because they're like 30 or 20. And if they had those risk factors, they probably wouldn't contribute in that short of time frame in their life to cause that degree of large vessel, which I'll show you, damage and cause a stroke. Something acute happened. You can have no medical history and get hit by a bus. You can have a medical condition with no previous medical condition if something hyper acute happens to you, right? I broke my thumb playing baseball. I had no medical condition when I was like, 15. That's different than osteoporosis, right? So something acute here is happening. And again, go back to my bad salad analogy way back, right? But so do they have,
underlying, right?
Yeah, it's like, I would have to assume that in the process of this virus infection, which I am presuming, is causing this massive inflammatory response. I would have to assume that inflammatory and immunologic response has nothing to do with this, right? And magically, their genetic disorder, which are ultra rare, right? Just magically seem to unmask itself at this moment in time. And magically, some people have pulmonary embolism, and some people have heart attacks, and some people have strokes, but they're all separate things and they all have nothing to do with each other.
Right.
It's all comes back to the same thing. And on that box I showed the complement side, thrombosis, so promotion towards blood clot, hyperviscosity, if we've all seen like a mush, like a molasses, not like water, it kind of chugs
Right,
along.
that's a great analogy, right? Like a
You know,
thickening and a slowing
thickening,
of. Hmm.
generalized thickening of the blood. And actually, ICU nurses have talked about this. Many people have had blood draws. We consider that an IV, right? An intravenous line. When you give blood at the lab, or we're poking your vein, which is why the blood kind of just drips out. In the movies, we've all seen an arterial wound, right? Where the blood goes like shooting across the
Right.
high pressure blood. Well, in the ICU, for people that don't know, to more accurately check the blood pressure, we will place something called an arterial line. We'll
Hmm.
actually put a line or a cannulization in the artery.
Hmm.
And the nurses, very astutely, as usual, are saying the blood is clotting like right away. Soon as I put that thing in there, we're seeing just blood clotting.
Wow.
And that goes to show you it's not the arm or the lung or the brain.
Yeah.
It's a
It's a
generalized
systemic process.
tendency.
Hmm.
It's a generalized tendency towards prothrombosis,
Hmm.
meaning a generalized tendency to want to form thickened blood and blood clots, which we talked about is advantageous in a way because you're slowing the spread of infection.
Hmm.
But it's disadvantageous if you form a blood clot. And if it happens to form in the lung, you have a pulmonary embolism. If it happens to form in the brain, you have a stroke. If it happens to form in the kidney, we're seeing kidney infarcts, renal infarcts.
Hmm.
Sometimes it can be sluggish. You can have a stroke another way. You cannot get enough blood flow.
Hmm.
And if it's sluggish, right? If I put the parking brake on all the city buses, people are going to move slower around the city.
Hmm.
Same thing. You don't get enough oxygen, hypoxic strokes. So
Hmm.
you see this. We're seeing renal failure. It's not like they magically got a kidney disease. They're critically ill. They have low blood pressure, thickened blood. They're not able to get enough blood and oxygen to the kidney tissue.
Hmm.
So, and actually it's shunted away from those less vital organs, not to disparage the kidney, but they're trying to get it to the
Right,
lungs,
exactly.
the
Right,
heart, the
right.
brain,
Exactly. How do we preserve life? Yeah.
you got it.
And
So this is, I think, tied into the same underlying mechanism of a combination of inflammation of the actual blood vessel itself, and
mhm.
then also forming blood clots and thickened blood, which form the perfect storm in many people that have strokes. I can substantiate that it's not a genetic weird thing because Cornell, I believe, did a paper saying that the incidence of this is like 7% in the ICU, which
Mm,
is on par with the typical ICU population pre-COVID. The difference is we're seeing it in younger people, not older people. So what I mean to say is these genetic diseases are usually rare.
mhm,
This is no longer becoming rare. It's becoming as common as anybody else having a stroke. It's
mhm.
just all comers now and no longer these older people with risk factors.
Got it. Right. It's just a more acute process that we're seeing in everyone, younger and older people alike. And then it seems to me from reviewing what the treatments were, again, we're still looking at how do we help get the blood thinner. So whether it's aspirin or something called Plavix or clopidogrel, again, antiplatelet agents, blood thinning agents, apixaban in another case, clot retrieval in a couple cases, or TPA. So it seems that, again, the treatment approaches that have been taken are pretty similar to something that you would typically do in a patient who's presenting with a stroke, because we're seeing um, that, again, it's an acute onset, but ultimately we're talking about the same sort of thrombosis. We're talking about the same. Maybe you can comment a little bit on
Yeah,
that. I'm curious if
yeah,
you've had any further thoughts on like what might be the future of this,
yeah.
for these patients. Yeah.
Absolutely. So, there's a couple stroke, you could picture as a neurologist, probably one of my most common inpatient in the hospital consults is for stroke.
Mm-hmm.
So there are a couple instances that I can think that we treat stroke, a little differently. One would be vasculitis.
Mm-hmm.
So when you have that degree of inflammation, clamping down the blood vessels, like in lupus, you actually treat it with steroids or immunotherapy, right? Now, I'm not saying give steroids in this case because it can inhibit viral mechanisms, but immunotherapy, and again, complement, there's a ton of papers on C1q presentation in ischemic tissue.
Mm-hmm.
And it's both helpful and harmful in a way. It's interesting. But anyway, there is complement up there in the brain. It absolutely C1q can form in the brain, which usually we think of as immunoprivileged, meaning it has the blood to brain barrier. Complement does exist up there. So I think that falls in line with the theory. So in terms of future treatments, I think immunotherapy of the underlying process. This is a generalized thrombosis, I think, still mediated by the complement that we can help by treating it quickly with a complement inhibitor. So I think actually the strokes will improve if we do that. If you have an acute stroke, once the clot has formed, you do have to treat it like we normally would. So we've seen, alarmingly, a decrease in hospital presentations in stroke and heart attack. A lot of strokes present with numbness at first.
Right.
And people are like, especially here in Manhattan, do I really want to go to a COVID-infested ER for this? What if I slept on it funny? What if I pinched a nerve? The problem is you only have typically 3, depending on who you are, 4.5 hours to act from time of onset till we give something called alteplase or TPA, which is a clot busting drug. It's Drano. It busts the clot up. So if you are, by the way, this is just an aside, if you have acute neurologic symptoms at home, please, please, please note the time of symptom onset. We have to know when the symptoms started. We can't guesstimate to give you that to qualify you for that medicine. So please, if you have a rational thought in your head while that's happening, and I would understand if you were going berserk and were scared out of your wits, but if you can keep your wits about you at all, please note the type of onset and tell us if you're on any blood thinners. So the other thing is clot retrieval, mechanical thrombectomy. We actually will go up with a kind of a snake or catheter and get the clot out. I will say though that in terms of prophylactically thinning blood in the hospital, the challenge there, and I think I have a middle ground on how to address it. The challenge there is that some people who are sick enough with infections go into something called DIC. And they actually consume their platelets up and actually go from clotty to leaky and frankly bleed to death. It's awfully gruesome and very sad. They bleed to death. So someone might think, oh my God, I'm going to thin the blood of an infected patient. So what I would recommend, so first of all, an antiplatelet or like aspirin or Plavix won't particularly anticoagulate you. It will, and we see this in stroke, right? If you have small vessel disease, we'd probably give you something like an aspirin or a Plavix, antiplatelet. But if you have atrial fibrillation and you're forming big blood clots and hitting the large vessels, which I'll show you here in a bit, we actually anticoagulate you. We give you things like Coumadin or warfarin, Eliquis, Paradoxical, Xarelto. So how do we do that in the middle ground? What do I do in the hospital normally? If you were, let's say you had atrial fibrillation, and you were on a blood thinner, but you said, you know what, Dr. Pitts, I have to get a hip surgery. Right. And I can't be on that, but I also don't want to have a stroke. Well, there's always a risk taking you off it, but what we might conceivably do is put you in the hospital, put you on something called heparin. So heparin is an IV medicine that is usually dosed every few hours and can be reversed. So a lot of people who have been in the hospital have had a Lovenox or a enoxaparin, low molecular weight heparin shot. Yes. The problem is that's not as easily reversed, and that's in your system the whole day typically. So if you do bleed, oh crap, we gave you a blood thinner and it's in you. Same thing with Eliquis or, these are great outpatient options, but I want something that's rapidly reversible. And every few hours, I want to have the advantage of making the decision to continue that. So what I would conceivably do is patients that come in, go ahead and give them heparin IV intravenously and dose that every few hours like you normally would, and literally make the decision each time. Do we continue this? If somebody looks like they're presenting with DIC, you can withdraw that and reverse it quickly. And that's what we would normally do anyhow. I have had the gut-wrenching experience of treating somebody with something called a cerebral venous thrombosis, a blood clot in the veins of the head. Yeah. Those patients bleed in their brain because they have a blood clot. So we actually have to give them a blood thinner while they are bleeding slightly into their brain, because the reason why they're bleeding is because they have a blood clot. You have to dissolve the clot. We use heparin because if whatever forbid they have a bigger bleed, we can stop it. We know if we let the blood clot go, they will bleed and bleed and bleed and die. So we have to do it. So I would consider conceivably using heparin and just doing what we typically do, is just saying, look, we'll reverse it if we need to, but knowing that we're in this prothrombotic state, first of all, inhibit the complement, which I think is causing it in the first place. And secondly, give people a blood thinner that is efficacious, but can also be stopped and readily reversed. So this slide here is kind of depicting what I'm saying. So let me kind of orient everybody. So on the bottom left, you see this thing here. It looks like a starfish, but actually it's called a magnetic resonance angiogram. So it's an MRI. And usually when you have an MRI of the brain, the computer wipes out the blood vessels so you can see the brain. This is the opposite. We've removed the brain so you can see the blood vessels. The gentleman, the bald gentleman on top, is just to orient you. We're looking at these blood vessels from the back of the head to the front of the head. So those big legs you see on the bottom are actually called the vertebral arteries. They run from the heart all the way up to the back of the head, and you're looking forward. So we're kind of looking just like this gentleman is oriented. Now on the right, where the arrow is, if you look at the diameter or size of that little artery, so that's the middle cerebral artery. That is a large vessel. It is going out towards the ear, right? Look at it compared to the left. It's significantly smaller and tighter. And I don't know if any of you have ever tried to drink something like a milkshake through a coffee straw. I don't know why in the world you would do that, but that would be awfully hard to do. So the lumen or diameter of this patient, this is a patient with an occlusion there, and actually who has vasculitis. They have inflammation of the blood vessel. It clamps down and tightens, and actually that blood vessel is occluded. And what you're seeing is the rest of the blood vessel cannot get blood flow to the right. That patient, and I showed the gentleman here with facial droop on the left, the right side of the brain controls the left side of the body. So conceivably, this patient would present with left-sided facial weakness, potentially numbness, and that would also likely include the arm and the leg. Face, arm, speech, time, we talk about fast. I will also add vertigo as a symptom and vision loss as well. So you can see here how this could happen. This blood flow interruption causes these stroke-like symptoms through, I believe, a mechanism that is a combination of inflammation, which is immune-mediated, and forming blood clots inappropriately. And actually, if I go to the next slide, this is kind of trying to highlight what I was talking about. A combination of, first of all, it's not three different issues. It's not like some people have heart attacks and some people have pulmonary embolisms and some people have strokes. They all have the same problem. It's just where it manifests, you know? So it's a combination of inflammation and blood clots. So if you look at the top left, that is called a coronary angiogram. If you've ever heard somebody use the term, I'm having a heart attack, I have to go to the cath lab. That is what we're talking about. We put a catheter, almost like a smaller, more flexible fishing pole, up the groin, the femoral artery, and we get to the heart, and we shoot dye, which lights up on an x-ray, and we can illuminate the coronary arteries, the blood vessels. And if you look on the left, what I'm trying to highlight here is it's the same process. And then I'm also trying to show clotting and inflammation. So on the left, you can see they even wrote 100% blockage. So you see how that vessel cuts off. There's no flow past that. That's where the blood clot is. And that's what's causing the heart attack or lack of oxygen that's killing the heart tissue. So that's the right coronary artery. On the right, you see what happens when they put a stent. They pop that thing open, and now all of a sudden you get blood flow again.
Blood flow again, right.
Right. So that is kind of what we're talking about. Now, if you go to the right, I'm showing the same thing. That's a lung with a blood clot in the vasculature of the lung. It's the same thing. We just have these different names because before we understood this, kind of like my autoimmune analogy of I think they're all the same process up until it picks what it's going to attack.
Differentiates into, right, exactly.
But we didn't have that insight decades or centuries ago. People look so different. You know, a rheumatoid patient, again, didn't look anything like, you know, a lupus patient who didn't look anything like a thyroid patient. but really it's a similar
An autoimmune process.
process.
Exactly.
It's
Yeah.
just what they
And
inappropriately shoot at, you know?
exactly. And this is the pulmonary embolism, which is in the vein, in the venous system, but ultimately it's a clot.
Absolutely, it's a clot. Um, Also, I'd like to point out, so I've shown blood clots here of the heart and lung on top, but on the bottom, I also want to point out two important phenomena that are also happening that I think, I've talked about. I've claimed that the immune system is promoting such inflammation and tissue damage that it's causing thrombosis and vessel injury leading to blood clots. So remember, I'm on the hook for blaming this all on the immune system and inflammation, and I'm prepared to own that and substantiate it. On the bottom, if you look at the bottom left, we're seeing people with myocarditis and pericarditis. Myocarditis is an inflammation of the heart muscle itself. Just like you can have an inflamed muscle if you're I used to pitch after, many moons and pounds ago. I played baseball, and after I pitched the whole game or played first base, I had a sore arm. I had muscle inflammation. Your heart's a muscle. So we have immune-directed inflammation of the muscle itself, and also the sac around the heart. That's called the pericardium, pericarditis. So it's a combination of inflammation, which can make the heart dysfunction. You may not get enough output from the heart itself. So if you squeeze a water balloon, you want pretty close, at least in the heart analogy, you want over 55% of the of the water in the water balloon to be squirted out. So you want the heart to pump meticulously. You want it to pump forcefully and get blood out to all the major organ systems. And then you want it to relax enough so that it can fill with more blood and then pump again. If the heart is inflamed, it will pump too fast and not create enough output, and you can also have a heart attack that way. So you can have an inflammation-based heart attack. You cannot get enough, we call it an oxygen mismatch, demand mismatch, where you are sick and you are working under such intense conditions. Maybe your heart is going at 200 beats a minute. That's like pulling the trigger on a 6-shooter before you have time to load bullets in it. You have to stop and load it. Otherwise, you're pulling the trigger, nothing's coming out. If I squeeze the water balloon before you load it, there's no water, thus there's no pressure, thus the organs don't get any blood, thus they don't get oxygen. So you can have a stroke that way, or a heart attack, or a
Heart failure symptoms, and
we call that a hypoperfusion stroke. You can actually have a stroke that way. So the inflammation, and then on the right, you see the inflammation of the lung. The lung, of the two lung pictures, the one on the right is normal. So you see the black aerated lung. And on the left, you see the adult respiratory distress syndrome lung, which is identical to what my trial patients have looked like. And that's why 86 to 97% of people are dying. And that's why a ventilator will not, even if we force oxygen into those lungs, that's an inundated sponge, and you can't wipe a wet counter with an inundated sponge. You can't get air into that lung. So it's a combination of inflammation and blood clotting happening in the lungs, happening in the brain, happening in the heart. We're just seeing them as different things, heart attack. And what about stroke? And what about pulmonary embolisms? Like, they're three different things. It's thrombosis, and it's generalized.
right. Absolutely.
In my opinion. And so I wanted to point out one other thing here. So when we, everybody I think has heard of a deep vein thrombosis, or DVT, or most people have. It's a blood clot in the leg. So a DVT forms sometimes just through being in bed long enough. But if you remember the triad, it's, stasis, so not moving, vessel injury, that's a big one, vessel injury, and then thrombosis, so forming blood clots. You form a blood clot. Now that blood clot can travel from the leg and go to the lung. How would it potentially, remember, these are veins, so we're talking about artery strokes in the brain. How could that conceivably happen? And remember, I'm not saying any one of these mechanisms is the way. It's all three. It's inflammation, generalized tendency to form blood clots, probably vasculitis in the brain as well. But there's another mechanism. When we're born, we all have a hole between the left and right atrium, and it allows for flow back and forth. Usually the vein transports blood that does not have oxygen in it back to the heart. So you can take in a breath, load it up with oxygen, and it can be carried out in the arteries. So how would the vein clot get over to the arteries in the brain? In 23 to 25% of us, not a small amount, we have something called a patent foramen ovale. It's called a PFO. And so there's something called a paradoxical emboli. And when you have a blood clot in the leg, you can have a really bad setup here. In about 25% of us, that hole that I described does not close. It remains open. That's not a disease within itself. Countless humans have lived and died, lived to been 100 with a PFO. That's not a problem within itself. However, if you have a blood clot in your leg and it travels up through the heart, it can cross over to the arterial system and be pumped out. So when you look at these young folks, they could have a stroke, and even not the young folks, but let's assume we take away the risk factors. They could have a stroke from direct inflammation on the blood vessels of the brain, clamping them down, vasculitis, with vessel injury, the immune response that throws them into making sluggish blood, which impairs oxygen transport and can clot, forming thrombosis and activating platelets, so a tendency towards forming blood clots. And then also, if they get a blood clot in their leg, that can go to the lung and or the brain in 25% of the people.
So patent foramen ovale, absolutely, yeah.
So you start to see this kind of all come together.
Absolutely, and thank you for really just also, driving that point home that the way that we think about these disease processes that are seemingly different, and yes, they're different presentations, but different presentations of likely what's a common mechanism.
Yeah.
And I think that's so important to acknowledge and again keep in mind, and also when we're thinking about sort of intelligently targeting and intelligent treatment, and it really ultimately comes down to, again, in very simplified ways, to controlling that part of the immune system that's overreacting, that's not necessarily serving a purpose when it comes to fighting the viral infection, but that's overreacting in terms of, destroying the village to save the village kind of thing.
You nailed it. And, I think it goes back to the feasibility of so if you take it back to what I think was maybe like the first thing we talked about, Dr. Weatherly, you've been a doctor for a long time. Corona, I don't know how many countless people we've all seen in training and practice that had a cold, coronavirus.
Absolutely. All the time.
If you step back and even just take your doctor hat off for a minute and say, how many people have I seen with a coronavirus? Do I normally see people getting like pulmonary emboli and strokes and deep vein thrombi and, whited out lungs that I can't even ventilate? And, you name it, all the renal failure that needs dialysis in a perfectly healthy 30-year-old kidney. I think when you stop there and say and think of it that way, you make life easier on yourself, because you start to realize that, yes, the virus is in their system, but it's not what is responsible for the end organ processes we're seeing. Certainly it is the provocateur. I'm not trivializing its role. It'd be better if we never came in contact with it. A vaccine would certainly be welcome. But when you get to this stage, this is much more beyond the viremia, to quote the great Dr. Elena Michaela, beyond the viremia.
Right. It's the response to it, and that dysregulation of the response. Well, this has been, I have to say, such an enlightening, wonderful conversation, and really what a great overview, even for myself, in terms of recalling some of these processes and putting it all together. I really appreciate you putting it all together for us and sharing sharing your research, sharing your thoughts and synthesis of all of this information, as well as your clinical experience. I feel like it's been such a rich conversation and contribution. So thank you so much for that.
Thanks for having me, Dr. Weatherly. I really appreciate it, and your dedication to this whole situation has been inspiring. So we appreciate it.